All right, so we're going to go ahead and get started. Thank you all who have already started introducing themselves in the chat box. I am also excited as well to hear from our panelists and have this important discussion. So we'll go ahead and start. And let me just put this disclaimer in the background. I have kids home. I have a puppy, so we might hear all kind of things. So put that out there. So again, good afternoon. My name is Dr. Fayron Epps, and I'm an assistant professor of nursing at Emory University and a huge fan of our panelists today. On behalf of all the members of the Black and Gerontology and Geriatrics community, we would like to welcome you to this webinar entitled Aging and Health Equity Research as Social Justice, supported by the American Society on Aging, the Southern Gerontological Society, Grantmakers in Aging, American Geriatric Society, and the Health Aging Fellows at New York Academy of Medicine. This webinar is being recorded and will be posted on the BIG website. A notice to all attendees will be distributed once the recording is available. So as we get started, we have an expert panelist joining us today. Our expert panelists are Dr. Tamara Baker, Dr. Jennifer Manley, and Dr. Roland Thorpe. On today's agenda, our experts will discuss their stories and provide their insights on how to address aging and health equity research as social justice work. We recognize that these are difficult and often uncomfortable conversations that might bring up many emotions. Please know that we want to create a safe and brave space. Our intention is to educate and learn, and not to further oppress or cause distress. Please feel free to reach out to a mental health professional if you feel triggered and need help. So as we move forward, I would like to let you know that a question and answer session will immediately follow the moderated question session. The question and answer session will last about 15 minutes. You can type your questions through the control panel screen in the question and chat box area at any time during the presentation, or you can wait toward the end. So next, we'll go and introduce our panelists. To provide context for our attendees, I will give each panelist approximately 3 to 5 minutes. You don't have to take the whole 5 minutes to introduce yourselves. Please provide your title, affiliation, research interest, and any research articles, projects that may be related to this topic for today. First, we will hear from Dr. Roland Thorpe.
Oh, so I was trying to write down what you wanted me to do with all the stuff, Dr. Epps. But first of all, I want to say thank you to yourself and to the organization for allowing me to come here today. And I'm just honored to be on the panel with Jennifer and Tamara. So I'm a professor in the Bloomberg School of Public Health. I'm the founding director of the Program for Research on Men's Health, and I co-direct the Johns Hopkins Alzheimer's Disease Research Center for Minority Aging Research. My research, I'm trained as a gerontologist and an epidemiologist. My research focuses on trying to understand race and SES differences as it relates to improving the health and well-being of African Americans. For the last 8 to 10 years, I've been focusing largely on Black men and Black men's health. And the other thing that I wanted to highlight for me is that I have this keen desire to create and mentor and develop the next generation of scholars of color. It's one of the things that I do, and it's one of the key things that the Rick Morris centered around. But in addition to doing that, I've honored to serve in becoming the inaugural Associate Vice Provost for Faculty Diversity at Johns Hopkins University. So I'll stop there and I'd pass it on to, I think Jennifer's next.
Yes, thank you so much, Dr. Thorpe. Can I be in that mix of you mentoring the next generation?
You got it. Come on. It's just that easy. It's just that easy.
That easy. Y'all heard, everyone, y'all heard, it's that easy. All right, next we'll hear from Dr. Jennifer Manley.
Thank you very much, Dr. Epps, and congratulations, Dr. Thorpe. That's such good news, and we're all celebrating with you. I'm a neuropsychologist and a professor in the Department of Neurology at Columbia University, and I have been working for quite some time on sort of life course, social forces and how they impact later life cognitive health among Black and Latinx people. And I have been guided by participants in a really amazing study in Washington Heights to take a look at educational experience and investment in schooling and how that relates to later life cognitive trajectories. And I'm, like Dr. Thorpe, the co-PI of one of the Alzheimer's disease resource centers for minority aging research. So that is one aspect of my my career where I facilitate that training grant, and which is focused on diversifying the workforce of people who are investigating Alzheimer's disease. I am also really involved in a number of studies that started in adolescence as different kinds of studies, like studies of schools and studies of education that are being leveraged now 50 years later to understand early life impacts on later life cognition. And I'll stop there and hand it over back to Dr. Epps.
Thank you for that. And next we'll hear from Dr. Tamara Baker. And Dr. Baker, you have 2 minutes. Now, I'm just joking. He's like 5 minutes. How can I?
5 minutes was a long time. Like, I don't have that much to say. But thank you, Dr. Epps, for the invite. And like Drs. Manley and Thor, very excited to be here and to serve as part of this panel discussion. Again, I'm Tamara Baker. I'm a professor in the psychiatry department at the University of North Carolina at Chapel Hill. I'm in the School of Medicine. And I'm also the associate director of research for the psychiatry department mental health equity program. My scholarly work really focuses on, examining disparities and inequities in pain management, particularly among older adults, but specifically older African Americans. I also look at the access and availability of services and resources when it comes to pain management. And more recently, my work has sort of morphed into examining overlapping painful medical conditions, specifically among older adults that are diagnosed with serious and persistent mental illnesses. So that's a relatively new but very exciting area for me. And we do not have a RICMAR here at UNC, but that is in the works. So I'm letting everyone know that hopefully soon enough that we can have a RICMAR that is in collaboration with UNC and Duke. So fingers crossed with that. But again, very excited to be here. I do have some resources that I'll probably share later on and we'll also put in the chat, but I'm going to stop for now and we can start our discussion. And thank you again.
Sounds good. Well, thank you all for introducing yourself, and we will move into the questions as we talk about our topic, aging and health equity research as social justice. And I just want to put this out there just to let the panelists know, please keep it real with us, right? Don't sugarcoat anything. Okay, Dr. Thorpe? This is such an important topic. And so I just really want us to just dive in and have some good, great, and honest conversation about this. So our first question that I would like to ask is, what are the often overlooked areas of aging research that perpetuates aging and health inequities experienced in Black communities? And I'll go ahead and start with you, Dr. Thorpe.
Yeah, so I think one of the most often overlooked things that is in gerontology, particularly, is the notion of not being able to have the life course perspective. So many of the, I'm so excited to hear that Dr. Manley is working on studies that they're going to leverage studies from early in the life course. Because oftentimes, of course, the NIH funded studies often has traditionally started at age 65. We know HRS started a little earlier, but many of them start at 65. And you just don't show up at 65 and start to fall apart, right? So it's that you have these cohort studies that are truncated and that what I call their left censored. So you don't get information early on in the life course to be able to see how these early on life courses, these events that occur early on in the life course, how they impact later life outcomes. That's one of the things I think that's overlooked. And I think we're in a space now when it comes to funding. I don't know how many more cohort studies we're going to get funded out of NIH anymore, seeing how most of the work now is moving toward interventions and multi-level interventions. But I think that is one of the most overlooked areas. And then the other thing that I would say is that I think we're at the point when we're thinking about health disparities work and moving toward achieving health equity. I think we pretty much know that the difference exists. So we don't need to continue comparing Blacks to whites or Latinx to whites. We know the difference exists on a number of health indicators. Let me be clear. Some health indicators we don't, but many of them we do. And we need to think about moving toward looking within groups and being able to understand the mechanisms that operate. Because if we can understand the mechanisms that operate and improve the health and well-being of those particular groups, then I think we then can close the gap that we had observed before. And I'll just stop there.
No, thank you. Thank you for that. Dr. Manley, any comments or anything you would like to add?
I thought that was great, and I'll just pick it up, which is if we're going to move on beyond the comparisons, then I think that one of the overlooked areas is not to just import then your conceptual model from those that have been standardized, quote, on white people and centered in whiteness. I think that what that creates is a situation where we're missing a whole world of factors that are unique and yet incredibly important to the minoritized populations, to Black people, to Latinx people, to indigenous populations, and lumping groups together when in fact they're actually very distinct and have experiences that could never be measured. If you look on the Phoenix website for social determinants of health, I think if you were to take the basic package, you'd be missing a lot of information about how Black people live and how those factors relate to later life health. So I think that's one piece. Another piece is one thing that's overlooked that I would just want to highlight from what Dr. Thorpe was saying is that if you recruit in a certain way, if you recruit from a convenience sample, then you don't know anything about the people who you didn't get, and your information is going to be warped and biased. And so the one thing that's overlooked in our research, I think, is our ascertainment bias.
Okay, that's good. Now I do have a follow-up question, but before I go to that, Dr. Baker, would you like to add anything?
I have nothing else to add. I mean, their responses are excellent and on point. But I was just kidding about not adding anything, but sort of echoing what Dr. Manley mentioned, I think a fact that's overlooked, and it's very basic. We often think that older Black adults are, they're a homogenous group. They're very diverse, very different experiences. And I think that should be taken into consideration if we are to continue this narrative about focusing on the needs and health outcomes of older Black adults. And one of the reasons why I also mentioned that is because this even goes back to the very basics of how we define Black people in general, older Black adults. So a lot of times with our research, we're using the terms, even the most basic, African-American versus Black. And some people may not think that that is important, but again, these are two very distinct groups. And, you know, if we are to continue to have this conversation, I think it's very important to make that distinction because, you know, African-American is considered an ethnic group, whereas Black is considered a race group. And it's just for consistency. I see that a lot with the journal that I'm the editor for. And again, people don't often question that, but I think it's very important to understand that there's so much diversity within the Black population, particularly with older adults and understanding their experiences that they bring to the table. And again, as Dr. Thorpe mentioned, people don't start aging, you know, as soon as they turn 65. I mean, they have a wealth of experiences that they come to the table with, and that's something that we definitely have to continue or start and or continue to address. Another thing, and just what Dr. Thorpe had mentioned was that, you know, it's really important to understand not only the diversity amongst the group, but, you know, we're beyond descriptive analyses. I mean, we know that there are differences, and I think that's very important to understand. There are some areas, as he mentioned, that we still need to focus on, and I'll just even use my own area of research looking at pain among older Black adults, but we're done describing. We need to move on. How can we translate what we found into something that's more applicable, something that can, you know, translate into an intervention in the community?
Thank you for that, Dr. Baker. And can you share with us what journal you're the editor for?
Ethnicity and Health. It's a Taylor and Francis journal.
Okay, thank you. And I think that's a good point that you brought out for many of our attendees to understand that Black refers to race, African-American refers to ethnicity, because I agree with you when we're looking at literature, and sometimes I get tripped up as well. And so I'm just like, I just put it all, you know, and so really trying to understand that. Dr. Manley, I wanted to go back to what you had said about not being able to measure some of the experiences of these individuals from communities of color. I find personally, when I'm writing a grant, or they want to know, they're looking for certain measures. They, you know, maybe the stress measure, burden measure, and I'm wondering, is that what you're referring to, or are you referring to other measures that just really don't make sense in measuring in this population? I'm
talking about it all, but
okay.
You know, I think in particular, I was talking about, you know, in my, I'll give you some examples. In my research, I have been involved in creating cohorts of Black people in order to understand more fully the interaction between, you know, some of the structural, environmental, and social variables, you know, that are considered important for cognitive outcomes, and genetics. You know, in our field, when people do find racial and ethnic differences, they jump to sort of account for those racial differences by bringing up genetic differences. And my solution to that was, okay, let me write a grant to do a genetic study and then show them how little the genes actually have to do with it. So, and the one way that you can do that is actually measure some of the social variables that do influence those outcomes. And you need to also measure the genes. So you need to be able to get the biological samples to show how these interact, if at all, and what the you know, attributable value is for each of these variables. So I guess one of the story that I was actually trying to tell was that a lot of the genetic studies out there that collected data on people with African ancestry don't even properly measure things like years of education, or don't collect data on birthplace or residential history. And all of that is incredibly important. And then, go forward with analyses that are looking at African ancestry and some of these important health outcomes, without taking into account the social factors that are, inextricably correlated with African ancestry in our country. So if you don't measure it, if you don't think about it, you're not thinking about race as, being this, the racial effects on health are really driven through racism and that whole legacy of racism in our country, then you're not going to be thinking about the right things. On the flip side, I'll just give a shout out to Marilyn Thomas, who's a postdoc at UCSF, who's looking at some really fascinating information about historically Black colleges and universities and how that relates to later life health among Black people. I mean, she's one emerging scholar in a group of people who are looking at some of these resources that are unique to Black communities, that may not just affect the people who are attending those universities, but also the communities around those universities. Mm-hmm. So I'm really excited about her work, and that's one example of how, when you really are thinking about, when you're not centering your questions in white people, you can actually come up with some really important ideas that are going to move our science forward.
Thank you for that, Dr. Manley, and further elaborating. And don't go off mute. You got to come off mute. I got one more. You talked about ascertainment bias. So that's a term that many may be unfamiliar with. Can you just do a short explanation on what that is?
I'll give an example. So I think probably everyone in this call who kind of works in a clinical setting might know that and there's a lot been published on this too, which is that Black people who, for example, come in to a specialized memory disorders clinic at a well-funded university tend to have not only more severe dementia problems than the white people who come into that same clinic, but they also tend to have more neuropsychiatric issues like, wandering, aggression, paranoia, irritability, and that sort of thing, which, if you were to sit back and kind of take that without being critical of it, you would say, oh, it looks like Alzheimer's disease is different in Black people than it is in white people, right? Because it's associated with it's much more severe, and it's associated with all these neuropsychiatric symptoms. But actually, there's a ton of Black people who just didn't come into your clinic. They just didn't go there because it's not a resource for them, because it's not a trusted place. It's not an accessible place. And so a lot of papers, a lot of our literature is based on those convenient samples, a lot. And we just have to, recognize that there needs to be a different kind of recruitment if we're going to understand, older Black people.
Yeah. Thank you for that. So we'll move on to our next question. What are the widely accepted assumptions in contemporary aging about research fields regarding Black communities? And we might have touched a little bit on this, but I'll come to you, Dr. Baker, to get you started, to get us started.
I appreciate this question. And once again, I appreciate what Dr. Manley mentioned, looking at the neighborhoods and the communities. I'm really fascinated, would love to learn more about the scholar that she mentioned and looking at HBCUs and the communities around HBCUs. Again, I'm a product of an HBCU, and I recognize how much of an impact, attending actually 2 HBCUs had in my life, but then also understanding that there was a community around my institutions. But I'm not going to focus on that because I love my HBCUs. But again, I think I really wanted to back up, and I don't think I'm going to necessarily answer the question, but I will try to in the best way. One of the things that I find, particularly in doing this type of research and being a scholar in gerontology and in psychology, is that we don't have a clear baseline when it comes to understanding health and health outcomes, particularly among older African Americans. I remember attending a conference once, and the scholar who was presenting mentioned this, and it was like a light bulb went off, because oftentimes when we do research, we are comparing Blacks and whites and what have you. But again, the standards that are placed for Black individuals are based on white samples. So again, I think it's very important to understand what is the baseline. And I appreciated, the type of training that I received when I was in graduate school, and even continuing that line of research now, is looking at the group with, within group variability, because I think that has a lot to do with forming those baselines. Again, in doing pain research, a lot of the work and the outcomes that we find, particularly among older African Americans, is based on what we have found among older white adults. And we need to start figuring out, so when it comes to pain severity, pain intensity, et cetera, just like with Alzheimer's disease, what is the baseline for older African Americans? And I sort of skirted around that particular question, but I wanted to put that out there, because all of these questions, when you think about it, really relate to one another and the information we're sharing. But again, one of the things that I want to emphasize is, what is the baseline for your population? What is the baseline when it comes to a particular illness or chronic condition? And I'm going to stop there. But again, I'm really fascinated about, focusing on the community, and particularly looking at the initiatives around HBCUs. Going back to that again.
Yeah, no, I'm focused on that too, because I am a 2 times grad as well from HB. But I'm a shout out Tuskegee and Southern. Dr. Baker, you're not
North Carolina Central University and Norfolk State University.
Oh, it's all love. So, Dr. Thorpe, would you like to piggyback on anything that Dr. Baker said? Do you need me to repeat the question?
No, I don't need you to repeat the question. But I'm not going to piggyback on what Dr. Baker says. I think I'm going to take a stab at answering it myself, if that's okay with Tuskegee. Yes. Okay, all right, because I'm Florida A&M. Anyway, one of the biggest assumptions that I find is that all Black folks, you can recruit them the same way as you recruit everybody else. It's easy to recruit Black people. We just need to go to the barbershop or go to the church and we'll get them. And that's another form of ascertainment bias. I think going to the churches and I think going to the barbershop are incredibly important places to go, but they're not the only places to go. And that's a lot of it is an assumption. When our other colleagues think about it, they typically come and say, oh, let's go to the church, or let's go to, and that those studies that are done in the church, they're well designed, well informed, and well intentioned, and great. And we've done some work in this area, but it's not the only place. It's just like what Dr. Manley said earlier. It's just not the only place. And you can't, and you make the assumption that if I can recruit Black people and you can recruit Black people in Chicago, Illinois, you can recruit Black folk down in Macon, Georgia. It doesn't, it's not the same. There's context that's driven in there, and there's relationships that needs to be created and built when you're engaged in these. But oftentimes what I've been seeing here lately is that there's this huge overlaying assumption is that we can go get Roland Thorpe, he can recruit folks. If he can recruit folks down in Alabama, he can go recruit folks out of in South Central LA, which is not true. I think you have to understand the communities, and you have to understand those communities. You have to build trust in those communities. Dr. Lisa Barnes has her Mars study, and I really like the process that she went through, and when she built the recruiting, that entire process. And I've heard her story twice, and I think it is one of the most remarkable stories you can hear about building a Black community and building the trust and getting questions answered, getting variables that can answer questions that push the boundaries of science. And the last thing I think one widely accepted assumption that I think I see a lot of times in my research is that failure to account for historical context can oftentimes lead you to egregious conclusions. Right. And so I think we need to think about, I'll say that one more time, because I know y'all recording, y'all don't think I could do it. Failure to account for historical context can oftentimes lead to egregious conclusions. Let me give you an example as it relates to studying Black men. right? If we don't take care of, if we don't understand the historical context, then, and we think about this wealth disparity that exists late in life, you think about they had different GI Bills coming out of World War I. You could go, I mean, World War II, you have these different GI Bills, and those GI Bills were designed for whites, they could build how they can buy homes, the black, where they can go to school. There was no limitations for them, but the blacks, there were certain schools that they would pay for. And those types of things could set you, we already know those early social conditions can set you on a different trajectory, economic trajectory and health trajectory. I'll stop because I'm getting revved up. Now you hear the piano in the background, Tamara?
Yeah,
ready to go to church. We can go to church.
No, wait, Dr. Thorpe, you just really made some good points. And these are assumptions. I have witnessed these assumptions that are being made, widely made, especially by my colleagues. So I thank you for taking out time to point that out and to give us that passion. And I think we all need to take into consideration. And when we are approached as Black scientists based on some of these assumptions, that we do need to address them head on as well. So thank you for that. Dr. Manley,
I'm sorry, Dr. Epps. I do want to piggyback off of Dr. Thorpe, and I think that he made some very good points. And I think it's also very important to call people out when they try to make the assumption that if you recruit in place A, that is going to serve the same as place B. And again, oftentimes we are brought on board to many of these research projects to help with recruitment. I know I've experienced that many times. And what happens is that, the individuals that are actually doing the research, they do not want to go out into these communities. They don't want to make the contacts. They don't want to establish the communication and the trust. And the thing is that as a Black scholar, a Black scientist, you have to let them know, look, just because it's in neighborhood A doesn't necessarily mean that I know this community. And just let them know, look, you have to be willing to go out into these communities and to recruit these individuals, that you just can't have that one Black face as part of your research team just to recruit. I think that's critical. I think that's very important. And oftentimes that's what happens when they need, a certain number of Black individuals in their studies. They say, let's get Dr. Baker to help us to recruit and to figure it out. And again, you have to be willing to go into these communities and to work with these and establish relationships. It's not just the responsibility of Dr. Baker. And we see that all the time. And it continues to happen, and it's very unfortunate. But again, you have to be willing to also call people out, to let them know we cannot continue to do this. You have to be willing to take that step as well, to learn how to communicate and learn how to recruit certain individuals if you are serious about doing this type of study or research.
Amen. Amen. I say that a lot because it's a lot. It's burden on us as Black scholars. You're giving us this, and it's like, because you don't want to step outside of your comfort zone. And
we some tough folks to recruit too. Let's just call it what it is too.
Wait, what you say?
We're some tough people to recruit too. So let's call it what it is too, right? You got to roll up your sleeve and do some work. It's not like we're gonna run up in there. I call it a labor of love. So, and I enjoy it, but you got to recognize there is actual effort, true effort involved in this, not just the 5% on the sub. There's true effort,
Yeah, but linked to that effort then is investment. And so I want to turn it around, like, that burden, it's a burden because of the expectations that people are gonna, make something out of nothing, and that it's gonna be the same investment as it is with other populations that are traditionally included in this research. So I think that part of the education that needs to happen, in addition to it's not just that one Black face, it's not just that one navigator that you've hired, and it's not your students either who are Black, who are going to do this for you. That it's actually a lot of investment, and that means resources, and that the expectation should be that it's engagement, full engagement and partnership with the community, and that takes a ton of time, and that is not going to happen if your grant is already funded. It's too late.
Right. Absolutely.
Yeah, and start on those relationships right now
Absolutely.
at day one. So
Can I just give a tip? Because I don't know how much, what I just want to give a tip. This is just Roland only. It's not even Dr. Thorpe, it's Roland. If you come ask me to be on your study to help recruit, I need to be in a leadership position. Straight up. Because that lets me know you don't know, or you don't, if you know, you don't have confidence that you can pull it off, but you're not gonna just have me on for 5 or 10%. Because if it's that important to you, it needs to be important at a leadership level. And the one other thing I want to say real quick, we haven't touched on this, but I think it needs to be said. Recruitment is important, but just as important is retention.
yeah.
And oftentimes when we talk about putting studies together, retention isn't really talked about. And then if you don't budget for retention, then well, how are we gonna keep them engaged and blah, blah, blah. You got retention and recruitment in my mind are to operate hand in hand.
Yep. I totally agree. Even as an early investigator, it does. And it takes effort as well.
Yeah.
For retention. As we move forward, I'm paying attention to the time. I think we kind of talked about maybe, or if anyone have any thoughts about any concerns of aging in the Black community that's often overlooked that we did not talk about.
I just want to quickly add one thing that of this concept of accelerated aging. So, Dr. Thorpe was talking about life course, which means, we can definitely, work harder to get more information, either directly or retrospectively from people about their experiences throughout the life course, that aging doesn't start at age 65. But what we found is that, biologically, if you start with Black people at age 65, you've missed a lot of the action time when things are really happening. And so I believe to understand inequalities in health in Black people, you've got to start actually measuring some of these. Aging starts earlier. And so that means you're convincing your funders, right, to have you start a project on something that's traditionally seen as an older person's question in people who are younger. And that is a challenge, but it can be done.
Right.
Thank you. And Dr. Thorpe, I seen you came off of mute. Do you have anything to add to that?
No, I don't.
There is one question that I would love for you all to speak on is why is research in the Black population a social justice issue? For those that may be listening and don't quite get it, can you all speak to that?
To me, social justice, is the idea that living a healthy life is our right, and that there are there's deeply unfair conditions that are because a certain group is being discriminated against and being structurally excluded from opportunities to the benefit of another group, and that is maintained because of that benefit. And so health itself is a justice issue. To me, doing this kind of research, which sometimes includes a exposition of what the inequalities are and where they start and what they look like, is a part of resolving, and a step in moving toward making sure that everyone has equal opportunity to have good health.
Yeah, thank you for that, Dr. Manley. Doctors Baker or Thorpe, would y'all like to add anything?
Yeah, so again, I think Dr. Manley hit it on the head. And, when you talk about social justice and even it's in relationship to research, again, as she mentioned, you're talking about opportunities, but you're also talking about access as well. Again, it's access to care, but then also access to resources. It's a right, as she mentioned, to be able to have access to care and quality care, particularly in the Black communities. And then even along the lines with social justice, we also have to, address the issues around equity. That's really what it is that everyone wants to be treated fairly, right? Everyone wants to receive services to make sure that they're living the best life possible. And really, that's what social justice really addresses. And even in doing research, you want to make sure that you're doing the right research, that you're asking the right questions, but then you're also doing research that's going to benefit the community. We're not just doing the research to have more grant dollars or something else to put on our CV. We want to be very intentional and very purposeful in the type of research that we do, and that is doing good quality research. And again, that is what social justice is all about when it comes to addressing the needs of our African American or Black communities.
Thank you. Dr. Thorpe?
Yeah, I'll just add one thing. I totally agree with with what has been said, and I wish we would have started with this question because now I'm calm. They got me riled up, Dr. Manley. Now I'm calming down. So no, the only thing I want to add in all of this, and I completely agree with what's been said, is that when we go in to put out our messages and disseminate our products, whatever they may be, we need to write from a positive standpoint. We no longer need to write from a negative standpoint and continue to stigmatize, because that's not a justice framework, right? So we need to write from a positive standpoint, right? We no longer need to say Blacks fare worse than blah, blah, blah. We want to, because if we're trying to go in and elevate our communities, if all the messages I hear is you broke, you cribbed, that doesn't empower me, right? So we want to think about writing from a positive framework and a positive stance.
Yeah. And so that's actually that's a shift. That's almost like a paradigm shift.
That's why you got Dr. Manley and Dr. Baker on here. I just sprinkle the paradigms in. No, it is.
I'm sorry. Go on.
I say it is. I was saying, making a joke of that, but it really is important. The message and how the message is delivered and received. It's very, very important.
Mm-hmm.
But, I just wanted to mention also is that, like Dr. Thorpe said, we don't want to work from a deficit model, but when you think about it, that's really how we've been trained. Mm-hmm. In graduate school. I mean, this is traditionally how we've been trained, from this group A does not do as well as group B. And this is how we present the information to show that one group does better than the other. And I totally agree with Dr. Thorpe, is that we can no longer continue to do this. Is that if you want to address issues around social justice, we have to make sure that we are uplifting the group that we are doing our research on. And it's not just from this model that that there's a problem, that something's wrong with the group. And it's okay to mention that, Blacks are doing better than whites. I mean, that's just the bottom line. And even with my journal, and when I get submissions and people are comparing groups, for example, and like Dr. Thorpe said, it's showing that, for example, Blacks are not doing as well as another group. And my question to them is, why are you even making these comparisons? What is the point of comparing whites to Blacks? And if they cannot provide a justification with that, I'm not saying I always reject the paper, but you need to provide me a very good reason why you are comparing group A to group B. and not just showing that one group is doing worse than the other. And I'll stop at that because I could talk about that for the next 5 hours. So.
No, thank you for that. And I'm going to move over to our question and answer segment. We have some of the attendees put some questions in. And I'm not sure if we'll be able to answer all, but we can take a stab, right? We have 12 minutes left. One of the attendees asked, can someone discuss the effects of race upon aging, intellectual and developmental disabilities within that population? Do any of you have any experience or expertise in that?
What was the question again?
What
was the question again?
The effects of race upon aging IDD, which is the intellectual developmental disabilities population.
I don't know that literature at all.
Yeah.
Me neither, but it's a great question.
Yeah.
And I know there is a very strong contingent of people who are interested in these relationships in the United States, and how the Alzheimer's disease, for example, the Alzheimer's disease funding relates to this population. And so what I have wondered before too, given what I know about those representatives and those advocates, is how the Black community is represented in those advocacy organizations. So, but I love this question, and I'd like to know the answer too.
Right.
Thank you. The next question is for you, Dr. Thorpe. Does historical context play a role in many other outcomes, disparities in frailty incidents, disparities in Alzheimer's disease, et cetera?
Yeah, I think it does. I think it absolutely does. If you think about, I think Dr. Manley talked about this earlier, particularly in her research, thinking about social conditions. Again, we don't just show up to 65 and start falling apart, right? My research showed early on that when you start looking at older adults at 65 and following them forward, they actually fare better on walking speed than whites. And because you have this crossover disability effect and this crossover mortality effect. But absolutely, I think the different social conditions and experiences that people had to endure over time, and that I think is the cumulative exposure that then creates these different trajectories over time. And so, yes, I think that you will see them. You might not necessarily see them in frailty incidents, but you'll see them in a number of health indicators. I do believe that I know there's a group, and I'm going to mess up their names. Dr. Manley knows them. Is Elizabeth Rose, is it Maeda?
Maeda.
Yeah, she's done some work on structural racism, life force stuff as it relates to cognition, or the continuum of cognition to the dementias. And it's another person, I can't think of her name now, but they're all out in the California area that I know of that are doing this life course, a lot of this life course stuff, which actually started from Dr. Manley and Dr. Glymore and their paper. If you haven't read it, is it the 2008 neuro? Yeah, I'm just trying to, I got an old mind. But yeah, it's a wonderful paper, and what is written there still impacts and is applicable to more than just cognition. And I use it all the time to make that point, because it talks about the intricacies and how things are intertwined, and it's difficult to disconnect them. And for us to think about pushing the boundaries and understanding synergistic effects that happen over time.
Thank you for that. Another question, we have a couple of questions that are coming in. I want to jump to the positive standpoint framework question, since we kind of just spoke about that. Someone asked if we can give a specific example of a statement from a positive standpoint framework.
So yeah, so I could take a stab at it. What I do, so particularly, for instance, I would not say in my writing now, I don't necessarily say that, in particular, I'm just looking at Black men, and we may be looking at depressive symptoms, and we may find whatever we're looking at that those who have more endorsements of the marks of depressive symptomology on the CSD, that they're more I guess they're more up to die. I would say, instead of saying that those who are depressed, I would say some areas that we might want to improve upon when considering, this depressive symptomology and its potential impact on whatever my outcome is blah, blah, blah. So I'm trying to take the stigmatization off of the Black man and to write about it in that way. And so it's still, the meaning doesn't change. It's just how it's framed that changes.
That's good. Okay. Anyone else would like to give any tips?
I would just, I don't think this is what the person was asking, but I'm just going to answer it in my own way, which is that I think that a lot of areas of aging research are focused on like what's now like termed quote lifestyle and lifestyle interventions. And what I always try to emphasize is the influences on what people do and what they can do and how they view things that are not about the individual and their choices. It's about some of the structure of their life, and indeed what we were talking about before, historical circumstances. And so I think that for me, on a paper to paper or research question to research question basis, I'm trying to take it away from some sort of blame model for individuals for not doing something, to recognizing the influence of both positive and negative of communities. I like some of the research showing looking at ethnic enclaves as neighborhoods that are supportive to aging in some cases. That's one example of sort of taking it out of the individual context and putting it into the broader context.
Okay.
Dr. Manley, I really like that. I just want to emphasize one point, because oftentimes we do put so much burden on the individual, and that individual is constrained by those structures that are broader than them, right? When you think about the social ecological model, that individuals at the smallest area, those other broader structures are constraining how that individual can move their lifestyle choices and all.
Yeah. Thank you.
And I agree with what Dr. Thorpe and Dr. Manley mentioned, and putting positive spin on your research. And I actually got this from Dr. Thorpe. He doesn't know this, but mentioning and being very specific about what is the benefit of doing this type of research. Mm-hmm. So again, that's where you can really put that positive spin, especially if you're only looking at a particular group and you're not necessarily doing comparisons between groups. It's really important to let the audience know very early on that the benefit of doing this type of research is X, Y, and Z. And that sort of sets the frame for the rest of the paper, for the results, for the methods, for the discussion. So I think, presenting that very early on is very important, and that can definitely shift how someone reads the science, but then also how they can even interpret the results as well.
Well, Dr. Baker, I learned it through the grant writing process. It was hard trying to get somebody to fund a study on Black men. And because I always got as you might imagine, Dr. Manley, why aren't you comparing them to white men? And you would get that all the time. For 3 years, I wrote it and hit, then I just refocused and it hit.
Yeah, great. And so we have 2 more questions to hope that we can address. One of the questions comes from Dr. Croft. Qualitative research is so important to bring out experiences in our Black communities. I agree, but it seems less valued by funding mechanisms. How can we more strongly convince funders that the narrative data is critical for centering Black experiences in our work? So do you agree? And if so, how can we convince funders?
Yeah, let me take a stab at this as someone who chairs the study section. I've seen an influx of qualitative work come in, and the study section that I'm on, they welcome it. We have the expertise. We have the expertise for mixed methodologies on there. And I've seen qualitative work, because I too, like the person sending the question, I too would have those reservations, but now having just sitting through and seeing how there's been a shift here, and, you know, NIH has embraced it because they have training grants around mixed methods. They have these toolkits out here. So they have embraced it. And I certainly would fully suggest that if you want to write about learning experiences or whatever group you want to do it, I think you should go for it. I think it is now becoming a common place at NIH. I've seen it, you know, NIH certainly does it, in NCI, NHLBI, those are the ones that I've seen, and there may be others, so I don't want to, I want to put that disclaimer. I don't know the case for the others, but I know it for those three, that they do welcome it. So I encourage you to do it.
Thank you. All right. So Dr. Croft, call your girl so we can get our quantitative
Yeah.
proposal in. Before I move on to the next question, anyone else want to piggyback on that?
I was just typing real quick, but I think that speaking extensively with program officers at National Institutes on Aging is going to help you with this thought process of developing a grant. I mean, Dr. Croft, if somebody's not funding Dr. Croft, that's a big mistake, mistake right there, just period. Because this person is doing amazing work. So we gotta, as a community also, I mean, I think there's all sorts of you know, maybe grant writing or you know, strategies that we can use to help each other, right? So I think this is why I love BIG. It's a community, and we can be working together to bring each other up.
Right.
Yes. Yes, and I love BIG as well. So our last question as we close it out, do you think that these strengths, the strengths of older Black Americans and their connections to well-being will similarly impact today's middle-aged and younger African Americans? Or do you see a difference in the strengths? I'm not sure if you all can see the question.
Let me see, can
you repeat the question again, please?
All right, so let me not paraphrase it. Let me just say how she has it.
Right.
And thinking about strengths of older Black Americans and their connections to well-being and health, do you think these strengths will similarly impact today's middle-aged and younger African Americans? Or do you see different strengths that will be more impactful in terms of health and well-being for middle-aged and younger African Americans?
That's a great question.
It is.
And I don't really have time because that's the one where the angels start coming. But I'll really say real quick, I think it's a great question. You know, I think that some of the strengths may be different and some of the factors may remain the same. So for instance, when we think about these broader structures, you know, I study segregation. I'm always intrigued how something has been outlawed for 50 years, but you still see the lingering effects today of it, right? And so the middle-aged, particularly the middle-aged African Americans, they're feeling some of the brunt of this today as well. The younger African Americans, not so sure how much of it they would feel, but that's one example of how one of the things that the resilience that comes out of it is one of the things that I think we can learn from there. But I think there will be some similar ones and there will be some different ones as well.
Okay. Well, thank you, Dr. Thorpe, for taking a stab at that. I want to be mindful of the time. I know everyone has other things to do, other meetings to join. And I just want to let you all know, the panelists, that I appreciate you taking out time to speak with us and for just keeping it real and sharing some great insights. And if there's any closing words, feel free to say them. But I want to thank you.
I appreciate you inviting me. I really enjoyed it. One thing I want to do is, I'm going to take a page out of Dr. Manley's book. Let us know when you get these grants. We want to tweet. I'm finally learning how to tweet, Jennifer.
You still need help with it. You still need help. That's okay.
I know. Listen,
you got to look at Dr. Epps. She's
Say,
good.
listen, somebody got to help. But look, I'm putting them out there now. The undergrads that were helping me graduated. So you saw the quality go down. But let us know, because that I know that absolutely, I'm absolutely happy to see it. I've seen some of your names come through. I'm happy to see them.
Thank you. Thank
Yep.
you.
Thank you for having us.
Yes,
All right.
thank you, Dr. Epps. It's been great. Thank you for
All right.
the
Well,
panel.
take
Take
care. Have a
care.
great
Bye-bye.
afternoon. Okay.
Bye.